Good evening, everyone. So we will make just 1 or 2 more minutes till we start today's webinar. Good to see you all here again. And so last week we had a chance to discuss a cardiology case, a cardiology emergency. And today we will have another cardiology case presented here. And so thank you all for last week's interaction, questions coming in, and theories to discuss. Was really good. So I expect to have the same activity today as well. And I'll just wait 1 or 2 more minutes till we start to let everyone arrive, and then we can go ahead. So, okay, let's go. It's 6 p.m. So welcome, everyone. Today's webinar is about cardiology emergency cases in the OSCE critical care course. So I will share my screen and you will be able to see my slides. Please feel free to interrupt me with any question at any moment. I will also ask some questions of you. Okay. So let me share my screen. Okay, just one of you, please let me know if you see my screen now.
Yeah, looks good.
Thanks. Okay. And then, oops. We are going from here. So I hope everyone has arrived. This is our second cardiology case this week. Last week we had a very good interaction. Let's go. So you are a medic at a remote film producing area with the crew. And the crew seeks your help. So they tell you that they found one of the elderly actors in his accommodation, as he did not show up on time for the filming. So they are quite worried, and they tell you that he's lying on the floor and he's in blood. That's what you hear. So it doesn't sound really good or promising. And when you enter his accommodation, this is what you see. This is the first link. You quickly do the primary assessment, the primary vitals. His CRT is 4 seconds. You try to get the pulse rate, palpate the pulse. It seems really bradycardic. It also seems it feels irregular. In general, it's really hard to palpate, so you are not really sure about the quality of the pulse, but it's definitely hard to palpate and bradycardic. The respiratory rate is 11, and the oxygen saturation is below 90%. So this is so far what we have. And I would like to hear your first impressions about this case. So the crew seeks help. He didn't show up. He was there for a while alone, and this is how you find him. This is how he appears. He's not in the blood, but there might be something going on. Red flags happy with these primary vitals? Yes, Michael, it's your turn.
Hello, Dr. Gara.
Hi.
I think the vital signs paint a picture of a sick patient. What's the level of consciousness of this patient this time?
Yeah, so you assess the ABPU scale, and there is some response to pain.
Okay. Yeah, so that confirms the initial impression. It's definitely sick.
Mm-hmm. Very good, right. So, yes, William, what's your opinion?
Is there any apparent life threats? Any source of the bleeding that we need to address?
Yes, you find some blood under the head. So it's not, it doesn't look a life-threatening bleeding. There is some bleeding from the scalp. And this is what the crew just, they were really worried and dramatic, and they told you that he's in blood. It's definitely not a life-threatening bleeding.
I would also say get a finger stick glucose if you have a glucometer.
Mm-hmm. Very good. Yes, Nelson?
Does he have any past medical history?
Yeah, so there's not much information at the moment about that. He is alone, and so no one in the crew knows about taking medications or anything like that about him. Bystanders, family members, no, they are staying in separated apartments. He was alone.
Okay, I would query a number of things. Initially, I would think about anything to do with the heart block, possibly pending the investigation on an ECG, and hypoxia, which I need to do a further investigation on that also.
Yeah, very good. Okay, so yes, definitely he's hypoxic and bradycardic, so we need to deal with these. So the ABC is not stable, so we need to work on that. Okay, very good. Let's move on. I'm hiding this. Yeah. Okay, so after the primaries, you do the secondary assessment, and no catastrophic hemorrhage, as I just said. So you find some blood under the head, so he might had a fall, and he might hit the head, and he's lying on his back, as you see. So the airway is not really clear, because the level of consciousness, just jumping to D, is B, so he is not perfectly able to protect his airwaves. So you need to take good care of the airwaves. He has bradypnea, so the respiratory rate is around 10, and he has some bleeding from this skull injury, which is not so much bleeding. It's not a life-threatening bleeding. And then, so there are a couple of bystanders, but he was alone, and they were trying to knock on his door to see what's going on, why he is late from the filming. So you are not alone. Some lay person is around, so you have a chance to get them help you in this scenario. Would you ask them to search for anything in the room, or how would you get them help you? Meds, yes, Tim, very good. So you mean to look for medications, or maybe empty boxes of medications? Was this the tip? Yeah, you can do that. So yes, very good, Tim. So yes, I would also try to quickly scan the environment, medical outlet, yes, to look for any possible signs of an intoxication, being it a medical intoxication, medicine intake, empty boxes. What else would you look for? sure you can look for any other types of toxics, empty bottles of gins or whatever. I would like to have some ideas. Yes, William?
In addition to meds, I would say if he has his own blood pressure machine or pulse ox, that's not something that somebody normally has if they don't have hypertension or some other sort of condition. So if you see one of those, you could probably assume it has something to do with that.
Yes. And also you can look for a glucose measurement equipment in parallel with the blood pressure, personal oxygen supply. Yes, Tim. So yeah, you try to find as many information as possible, because he is staying alone, and there's no family members or nobody around him to tell you what happened. So you need to quickly get as much information as possible. And it's always, you never waste your time with doing these. If you have some bystander, some layperson, someone around, and you can tell them quickly, look in the kitchen, look whatever, tell us if you find anything suspicious. You can also, it's always a good idea to have a look at the restroom and the toilet to see if anything catastrophic might have happened there. For example, severe garbage as well, very good. Severe vomiting, severe diarrhea, vomiting blood, things like that. If something very severe, life-threatening is happening, it must have some some remnants, or you will find some signs of that when you quickly scan the apartment. So in general, it's a good idea to do so when you find someone alone in a critical condition. Okay. Yes, and if you have time, if you have people to help you, you can try to look for medical documentation, maybe an ICD card, just referring for last week's topic. Okay, so this is what you can do. Okay. You go on. So in this case, there's nothing suspicious in the apartment. So no empty boxes of medications or empty bottles, or no sign of any intoxication, or it might be a suicide attempt or whatever, but no suspicious sign in this case, which is even worse because no more information at the moment for you guys. Okay, so you do the detailed secondary assessment. Now you can get the exact pulse rate, which is definitely low, around 40. You give high flow oxygen in a non-rebreathing mask, and with this equipment you get 92%. You measure the blood pressure, which gives you another red flag because he's clearly hypotensive. You get an ECG to see what's the rhythm, what's going on. The sugar level is good, so it's not a hypoglycemia or hyperglycemia. So the sugar, the glucose metabolic condition, it looks fine at the moment. And the temperature, what do you think about this? You quickly do the assessment. Yes, Michael?
What kind of environment are we working in? Is this like a warm country, cold country?
It's November, and it's 15 degrees in the daytime outside. It's around 5 during the night.
Yeah, temperature is a bit lower than It should be, but I don't think it's low enough to cause a symptomatic bradycardia at this level.
Mm-hmm. Yes, I agree, Michael, that the temperature is low, but it's not the preliminary reason behind the bradycardia. But it's not a red flag yet, but it's definitely raises the attention. Yes, Martina?
Maybe it can indicate some overdose of beta blockers or calcium channel blockers, cardiac medications, because we have very slow heart rate. The patient has not enough perfusion, and his temperature is low, but it's not alarming, but it's too low for the normal room temperature.
Yes, thank you. Very good idea. Yes, it could be the whole condition, could be, why not, a beta blocker intoxication. Yes, you haven't found any empty boxes or empty leaflet of the medication, but it might be that that the crew around you were mistaken, or he is just hiding those, or whatever happened. So yes, we always have to think about medical intoxications with these cases. And so about this temperature, I'm just trying to outline that it's really important early on to think about hypothermia in a ways that to prevent severe hypothermia, because this old gentleman, we don't know the timing, how long is he lying on the floor there alone in this hypotensive bradycardic situation. So elderly people can really quickly and easily turn into hypothermia, and it's worsening the outcome of any kind of acute emergency. So if you have the opportunity, as soon as possible, pull on a blanket, put an isolation blanket or whatever you have at hand to prevent further hypothermia. Okay, but sure, here we have more severe problems than the hypothermia, and we can continue, and the ECG is ready, and this is what you have. So I leave this on for a while, and then we can discuss. Who would like to start analyzing this ECG? Yes, Michael.
Yeah, it doesn't look great at all. Looks like a high-degree block, possibly a complete arc block, but without a long strip. It's a bit hard to tell, but there's definitely more than one drop P wave. It doesn't seem to be. Maybe there is some correlation between P waves and QRS, but without a long strip, it's hard to tell whether it's secondary type 2 or complete arc block. But there's either ventricular escape rhythm or some PVCs. Either way, there are ischemic changes in inferior leads and the anterior leads, septal as well, with some reciprocal changes in the lateral lead. So it looks like it could be ischemia of more than one coronary vessel. It definitely needs either atropine is probably not going to work, so probably pacing or pressor.
Okay, yeah, very, very good, Michael, thanks. So yes, just let's go step by step. So what we see on this ECG is clearly that it's a severe bradycardia, and yes, Michael, you were really you said really well that this is a high degree AV block, and also very good and right that from this relatively short strip, it's not possible to clearly tell what's going on, whether it's a second degree or complete third degree AV block. You always look for the P waves, and you can see them here, then some P wave-like morphology here as well. I think it might be No, that's not P wave. Okay, so you see that there we can find some P waves which are completely not followed by any QRS, and there are some other P waves which might have some relation with the QRS or might not. We have two ventricular beats. One is with this wider QRS, and this other one is it's a thinner, it's a not so wide one. It's again from this short strip. It's not possible to say if any of these beats is coming from it's a sinus or coming from the atria, or all of them or both of them are escape beats or ventricular beats. So yes, from this short strip, it's these detailed information. It's hidden. Okay. Yes, and then looking at this QRS, so this is a relatively wide QRS. So if this is a sinus QRS, or if it's in any way related to the sinus activity, then it's with a bundle branch block because it's really wide. And it's right that we have ischemic appearance or ischemic changes. At this ECG, it's hard to say whether these are true, whether these are mirroring the true coronary anatomy, or rather due to this severe AV block and due to the severe hypoxemic hypotensive case, whether they are secondary ischemic signs. Okay, but definitely cardiac ischemia is going on, and then we have this second beat. It might be from the AV node, or might be from an atrial activity, because it's comparing to the other QRS, it's relatively not so. It's relatively narrow. Yeah, and this other one, it's hard to say. This other one, this rather has an RBB or an incomplete RBB appearance. If you look in V1, V2, V3, and the mirroring signs. So, yeah. Questions or more comments to this ECG? I would like to fully discuss, and I would like you all to recognize these signs. I think it's quite clear that it's a severe AV block and some ischemic changes. Any questions? Yes, Michael?
Would you say that in the ventricular complexes, so say in lead 3, V3, V4, V1, would you call that discordant elevation? Excessive? Will you call it excessive discordance?
You talk about the wide QRS?
Yeah, I'm talking about the elevation that we see there.
Yes. So with this ECG, I would. Yeah, you can say that, because it's really hard to definitely say whether it's an LAD infarct or it's just a general cardiac ischemia with the hypertension bradycardia. Because if we look for the leads that are usually together, so then we have ST elevation-like appearance in lead 3, AVF. Lead 2 not so much. So we have some kind of inferior appearance, and then we have V1, 2, 3, 4. So that's anteroseptal, and those two are not according to the coronary anatomies. They usually they don't go together. So if it's a large circumflex, then it could be that it's an inferior, but then it would be together with the lateral region, and there's no ST elevation in the lateral. So inferolateral usually goes together with the circumflex. And otherwise, it can happen that he parallel has a septal infarct with an inferior one, but also with the inferior one, we usually see large ST depression in leads V1 to 3. So for me, just the mosaic is not coming together. It's not fitting the coronary anatomy. Yes.
Yeah, makes sense.
Yeah. Okay. Okay, you go on, guys. So what's next? Here we are. He is lying there, severe bradycardia, hypotensive, clearly hemodynamically unstable, and we see that ECG with a 3rd degree AV block. How would you handle this situation? Yes, Martina, go ahead.
Obviously, high flow oxygen. Some, if we have time, we can give some slight sedation and transcutaneous pacing, and transport to the hospital where we can insert the pacer, basically.
Mm-hmm. Okay. So first line, you will go for the transcutaneous pacing. Okay. I wanted to talk later about the transcutaneous pacing. I can say I'm not a fan of it. I mean, there are really, really rare number of cases where I have seen it working very efficiently. So I wouldn't, at this case, I wouldn't choose the transcutaneous pacing as a first line therapy, but it's an option. So you are right. Okay, it's an alternating BBB Van der Branch block, which progresses into high AV block, which is why we have the left Van der Branch block morphology and the RBB escape beats. So the AV block is kind of they are kind of individual. I mean, with the AV block, you have a complete block or 2nd degree. So you have a high degree block between the atrium and the ventricle. And so they are living individual lives. And when sometimes when the depolarization and repolarization, so when the timing is right, they can still get a fusion beat. So the atrial activity sometimes still gets some activity from the ventricle, and it's vice versa, the other way around, that we can see electric activity going back to the atria when this rhythm is coming from the ventricles. And so I would not define, or I would not say with this wording that this is an alternating Van der Branch block. So some beats are coming from the ventricle, being escape rhythm. So when the sinus is not functioning, then we still have the AV node and the whole ventricle to do some rhythm, so to initiate the rhythm. And then so it's not a classic Van der Branch block. It's just the appearance that this is from this, as I said, from this short section, it's impossible to say whether this P is clearly related to the QRS or whether it's just accidental finding here. We would need a long strip to analyze the whole situation. This has a and yeah, it's not really a classic Van der Branch block morphology. It's just a white QRS. Okay, so this is it. Yes, thanks for the comment, Jennifer. Okay. Yes, and Tom just said that no, unfortunately, I haven't seen these chats clearly. Sorry. So Tom said that atrial rate is about 85-ish. Yes, that's good. We can analyze that from the P waves. Okay. Good. So yes, for the therapy, Martina just said that she will give the high flow oxygen. Very good, it's already on. And I would be really careful with the sedation because this patient is already hypotensive, bradycardic. So first line, we need to stabilize the ABC. And also we need to care for the airway when the breathing is also bradypnoic. So we need to, in parallel, stabilize these. And so if you, I don't know what medication would you like to use for sedation, but let's just say midazolam or whatever you give for this patient, you can kill this patient with that. Until the ABC is not getting better and not stabilizing a bit, I would put second line sedation. Yes, that's clear that you can't cause pain and you can't cause more distress for the patient, but the AVPU scale is on P, so it can't get any more worse. So I would be really careful with sedating this patient early on. Yes, and then treating this severe bradycardia, the transcutaneous spacing is one option, which we will discuss today. But what other options we have? Michael, yes.
Either atropine, which it's probably not going to work well on a high degree block. So the other two options would be either a dopamine drip or an epinephrine drip.
Mm-hmm. Yes, very good. So we have good medications on hand to try to treat this bradycardia. I would try the atropine. It's quite quick and easy to administer, so it's not that long waste of time to give it a try. And yes, after it, and I show you, these slides are from your field guide. So after the dopamine, adrenaline, and some other drugs are also coming in. So we go on and discuss this. So you assess the bradycardia and the appropriateness of this diagnosis. And then you always try to rule out and treat really early on the secondary causes. So it might improve a bit when the patient is not anymore in hypoxemia. So you always maintain the airway, give oxygen, you put on the cardiac monitor. You don't waste time with the 12 lead, but it's most of the times it's really useful to have one. And so with the bradycardia and with any type of AV block, bradyarrhythmia, it's you can remember for lifelong that you only treat when the patient is symptomatic and hemodynamically unstable. What does it mean? When is a patient hemodynamically unstable? So it means that he's hypotensive, he has or they have a altered mental status, any signs of shock, any ischemic pain or angina, chest pain, symptoms of ischemia, or they are in acute heart failure. Okay, so if any of these presented, you need to really early on treat, and the first line is medication, and then I would keep the transcutaneous spacing for second line therapy when you fail or when the medical therapy is not working, or for any technical reason or for whatever reason you can't perform that. So if there is no hemodynamic instability, then you watch and wait, monitor and observe. Okay. Nowadays, and I'm just having a short section outside this case. So nowadays, many people wear these watches, these iWatches and whatever watches, which can measure the heart rate, and some of them can measure the blood pressure as well, or measure the different phases of sleep. And they have long tables of monitoring their vital signs and monitoring their sleep, and they create wonderful diagnoses from those, which are sometimes ridiculous, I tell you. And yes, sometimes these wearable equipment very useful, because sometimes we can get really good readings of heart rate. Maybe some of them can even do a one lead ECG. They you must have heard about them. You can attach a small device to your phone, and the patient can access one lead ECG at home when they are symptomatic. So yes, they are wonderful, but most of the people just use them to, I don't know, just to kill time, or they are really furious about their condition or the vital signs. And sometimes they come into the clinic and complain about bradycardia, and that they measure the 45 minutes per beat, and they are really worried that they have some heart condition. Most of them don't have any disease. Okay, but it's also happening with patients with known cardiac conditions and taking medications. Some of them feel that the beta blockers, the dose is too high, or it's causing them severe bradycardia. But bradycardia in general, it's a protective. When it's not causing hemodynamic instability, then it's a protective factor for the heart. Okay, so those who are really active and really sporty have lower heart rate in rest. So in general, we cardiologists, we are usually not too worried about bradycardia when it's above 40 and asymptomatic, then nothing to do. Sure, we do the assessment. We can do 24 hours tape recording Holter, so we need to safely rule out asymptomatic bradycardia. But in general, when a patient is without hemodynamic instability, don't touch the patient. Okay, when the ABC is stable, then don't touch it. Okay, so yeah. Okay, from here we can go on, turning back to this situation and this case. So this gentleman is clearly in a hypotensive situation, has an altered consciousness, some ischemic signs on the ECG as well. So yes, we clearly need to perform, and first line is atropine. If not, then you can try dopamine epinephrine, and I will show another medication on the next slide. So you can see the doses here, and this one is again from your field guide. And if the medication is not working, then you can try the transcutaneous spacing. I would like to show you this slide as well. This is from the European Society of Cardiology guideline treating the bradyarrhythmias. And so step 0 with bradycardia is always to rule out any underlying causes. And step 0B is to treat the symptomatic patients only. So you never forget these two. And like, for example, in this case here, it's hard to rule out the underlying causes because we don't have many information. We don't know the previous medical condition of this gentleman. it might be an intoxication, but we didn't find any signs of it in the apartment. So it's a hard situation, but that's why you are remote medics, because you can deal with these situations. So the ESC guideline also says that the first line is atropine. And this is another medication. I mentioned it last week as well. We have this isoprenaline. This is a beta-1, beta-2 agonist. So it is acting directly on beta receptors, and it's stimulating the beta receptors. Of course, it won't work if we have a beta blocker intoxication. You can see the doses here, and you can try adrenaline drop as well. Okay, and then comes the temporary pacing. Yeah, and this guideline, it's also it has be careful. So it's always second line, the temporary pacing, because it's a really an invasive. It's not an invasive, so you don't have to insert anything, but the complications are common, and it shall not be used routinely. So it says the guideline that use only as a last resource when the chronotropic drugs are insufficient. Yes, and you can see the indications, which we are already discussed quite thoroughly. Okay, and at this point, yes, I would like to ask you that tell me your experience with transcutaneous spacing. Yes, I can start. I've never seen those patients who are met at the field. I mean, in pre-hospital, and I was trying to, as a last resource, introduce the transcutaneous spacing. I mean, I only saw a couple of beats which were effectively paced, and otherwise it was just some ineffective pacing, or pacing the thoracic muscles, or causing severe thoracic muscle activity, and not so much efficient cardiac rhythm. So that's my personal experience, and I would like to hear yours. Tom, transvenous spacing, I was involved. Yeah, yes, I will also talk about the transvenous spacing a bit later on. Yes, Michael, you go first.
I've done it a couple of times, and I never managed to get adequate mechanical capture. The last time I used it was on a bradycardic hyperkalemic patient, and it was a quite big patient, and there was good electrical capture, and I thought there was good mechanical capture as well, but I think I just got fooled by like a muscle twitch. And of course, the patient was really uncomfortable because of the electricity. So I gave some sedation, thinking that, now the patient is paced, so they're going to be tolerating sedation better. But because they weren't actually paced, the patient actually lost even more pressure and tanked for a few minutes. So not something. If I had to go back, I would probably use a pressor first.
Yes. Thanks, Michael. Very good points. That I even didn't manage a good electrical coupling, and then we still, if we don't have a quick pocket ultrasound around, you can't be sure whether it's a mechanical coupling, so whether it's the heart is exactly pumping, because that's one thing that we see, the electrical coupling after transcutaneous spacing. So that's thank you for that. It's a very good point. And the other one was also a very good one, that unfortunately many patients are obese, quite corpulent, male thorax is quite big, much muscle on it. Female have the breast tissue, so it's all around just an anatomic disaster to be successful with the transcutaneous spacing. Yes. Martina, how about your experience?
So basically, I have a history of pacing a few times. I'm not saying that it's always was successful, but why I mention it, because actually 1 month ago we had a case, 94-year-old male who was in hard block for a couple of days, unconscious. He was on the infusion of adrenaline infusion, dobutamine. And obviously in some point he crashed. All vitals were going down. We decided to transfer him because where he was, we didn't have an option of pacing. And as soon as we arrived to ER, they paced him and the patient regained consciousness. And
so they paced him transcutaneously.
Yes.
Okay.
Yes. And immediately he regained consciousness, and he was
Very
getting
good.
infusions. They didn't work. And he was unconscious, I'm saying, for a couple of days. And considering 94-year-old, maybe because he was really small already, he was skinny. Maybe that's why this time it worked, but it worked perfectly.
Yes, the success rate on a skinny patient is higher. Thanks for this, telling us this case. And also, when you are during the transport and the ambulance car is moving, that's one more factor which just makes our efforts harder to be successful. Yes, okay, thank you. Good. So we can study from your field guide the procedure of transcutaneous pacing, which you all know quite well. So you try to up titrate the pacing energy till that rate, till that milliampere, which looks to generate electrical and mechanical coupling. Okay, and you need to take care of the patient if the consciousness level requires to sedate, not to cause more discomfort to this patient. Okay, good. And shortly, I would like to touch on the temporary transvenous pacemaker, which is not something available in pre-hospital situations, because you need to insert in completely sterile conditions. But in emergency department, cardiac emergencies, mostly it's really routinely used. The insertion is it's routine. It's easy. It's like inserting an IV line. You can insert a temporary pacemaker via the subclavian vein or via the femoral vein. We prefer the subclavian because from that side it's more stable. The position is not dependent on moving the leg or transporting the patient or moving the patient to the subclavian line. Is a stable one, and the line goes in to the right ventricle, to the apex, and then this is the equipment, the handler, where you can set the mode of the pacing. And in many cases, I'm not sure, might be different elsewhere, but a secondary transport between hospitals or to a CT scan, or if not available on site, or so a secondary transport with a temporary pacemaker is available, so the department can lend the device to the ambulance and they are able to handle it during the transport. And later on, the device, either they give it back or they just moving around between the different departments. So maybe one day with a secondary transport, you can meet a temporary pacemaker. Okay. Yes, and this is mostly our case. So at the end, I would like to, yes, and I have some more slides with an extra topic for bradycardias, but here I would like to just discuss this this gentleman we just found with the filming crew. How would you handle on the field? You give the medication, you hope for a good response. If not, you can try the transcutaneous pacing and then just evacuate as quickly as possible. Do you have at the moment questions, comments? Would you do something differently? Oh, Jennifer, sorry, I missed your message in the chat. So you also had a problem with the temporary pacemaker. Yeah, with the plane transport, even more movement. Okay, so yeah, it's with the temporary pacemaker, it's okay. I see that due to the movement, you had some problems and you needed to reinsert. Yes, unfortunately, sometimes they just dislodge. So it's really beat by beat. You need to monitor the patients with a temporary pacemaker. That's right. Thank you. Okay, Nelson, it's your turn.
Yeah. Yes, Doc. Just to check, does this patient have any focal signs?
Focal signs? You mean neurological signs?
Yes.
Good question. Yes. So you just did the quick neurology assessment, and according to that, no major neurological disabilities or no major neurological signs noted. So according to the treatment, the bradycardia and the hypertension just improved a bit. His consciousness level improved a bit, but no signs of stroke or other neurological disaster. Yes, but it's very good that when you have time, you do a detailed neurological assessment as well. Thanks for this point. So this, from here, so we have ended the case, and from here it's not directly related to the case, but as far as today we are talking about cardiac emergencies with bradycardia, I would like to outline the most common pre-hospital situation when you need to count and deal with bradycardia. And I think Michael he might slightly mention it. So I don't want to tell it too early. So if you guys have some ideas what I might be thinking about, and just slightly we have touched on this today, but it's clearly one situation when you need to count with bradycardia and it's a pre-hospital cardiac emergency. You meet this quite often. Yes, Michael?
Hyperkalemia.
Yes, hyperkalemia. That's right. But it's not that common as this other condition. But yes, hyperkalemia happens. And yes, it's a pre-hospital situation with bradycardia, right? And there's another one.
Ischemia of the right main coronary artery.
Yes. Okay. So we have this ECG, and this was performed with the LifeBook 15. So it has analyzes and gives you a written report, which you never 100% trust. So if you work with a LifeBook, I always avoid the written report. I always try to analyze myself, and then I'm kind of double checking. So once I've done with my job and analyzed the ECG according to my checklist, which I showed last time, then I quickly have a blink on the analysis of the machine, and most of the times I'm happy that they match. If they don't, then mostly the machine is incorrect. I mean, it's doing some mismatch or doing some noise analysis or whatever, or just it's kind of guessing that it looks something or appears something. And so you never 100% trust the machine. It can give you some hints, and and I've learned this. I'm using it the other way around. So I'm doing my job first, and then I'm just doing a double check to see what's the machine saying, because you can't completely ignore because it's written there. But machines are just machines. So artificial intelligence is wonderful, but human brains can be completely substituted by machines. Okay, what do we see here on this ECG? Michael? Yes?
Yeah, there is ST elevation in the inferior leads, 2, 3, and AVF. The elevation in lead 3 is greater than the elevation in lead 2, which from the latest evidence, we know it's possibly suggestive of right ventricular involvement as well. Suggesting that it might be a complete right coronary artery blockage. There's reciprocal changes in the lead 1 and AVL, so that confirms what we're seeing there. And it's a bit of depression in V2 and V3, V4 as well. Might be some posterior involvement as well. But
yes, yeah. So I agree. It's a large infraposterior ST elevation infarction. So, and according to the coronary anatomy, it's the right coronary anatomy involvement, and it's a severe bradypnea on this ECG as well, and AV block as well. So, what's the reason? And you can see the reason on this ECG. On this slide. So the reason is that you can see the percentage of the sinus node artery. So in most people, it's originating from the right coronary artery. It has usually 2 pathways to do so. And in 1/4 of the people, it's originating from the left coronary artery. So when there's a huge proximal right coronary artery occlusion, then the sinus node, is just yellow here, the sinus node suffers a severe ischemia, and for this reason it cannot function properly. So you can await severe sinus node dysfunction and a severe bradycardia. And we see this in around 90% of right coronary infarcts. So it's quite high. So you have to count with the bradycardia and prepare in your mind and also in practically to treat that bradycardia. And it's really quickly resolves. I mean, quickly in a couple of hours, it resolves after the percutaneous coronary intervention is performed. So it's completely reversible. That's good news, that the sinus node dysfunction is reversible in a couple of hours after the intervention. Okay, so remember that inferior, infraposterior infarct, you need to count with bradycardia. Okay, so this was it for today. We have a couple of more minutes for discussion if you have more questions, comments. Tim, yes? Yeah, no, it was not a question. Michael, you have something? Yes?
Yeah, so with bradycardia secondary to cardiac ischemia or in conjunction with cardiac ischemia, so say a patient that's bradycardic and the ECG is showing a STEMI, right, wherever, doesn't matter which coronary artery, how aggressive would you be in managing the bradycardia? The reason I ask you that is that here, where I'm working in Canada, for our local protocols, if if the patient is bradycardic and has like some clear signs of occlusive ischemia, we need to contact medical control before treating the bradycardia. They basically want us to get doctor's clearance before we treat asymptomatic bradycardia in cardiac ischemia. And most of the time, there's no issues with that. So my question is there really any risk? Like if there is, STEMI, say, and bradycardia, can we do any damage in using atropine and depressors?
Yes, thank you for this question, comment. So in general, I would say that if the patient is hemodynamically unstable, you treat the bradycardia, and sure, in an ischemic patient, it's not clear what from the hemodynamic instability is stemming from, but the bradycardia, it's definitely worsening that. So when there's a hemodynamic instability, yes, I would be aggressive with the treatment. If the patient is asymptomatic, and it even could be with a right coronary infarct, that it's relatively good blood pressure, you can give the treatment for the pain relief. They are conscious to STEMI, so we know those patients who are in a relative good hemodynamic condition, around 48 or 45-ish bradycardia, I would rather wait. So if no hemodynamic catastrophe, then I would rather wait. And the atropine, it's all right, it won't cause more damage, but with the other ones, the dopamine, epinephrine, isoprenaline, they can cause catastrophe in an ischemic heart. So because those are catecholamines, and on one hand they do the job and do the inotrope chronotrope support, but the other hand they can be a trigger for a severe arrhythmia, and the trigger for that on an ischemic heart is much lower. So yes, I would be really, really careful. So I don't know if it answers your question.
No, thank you. Just to make sure I understood correctly, if the patient is hemodynamically unstable, whether there's a STEMI or not, we should manage that
aggressively. Yes.
And atropine would be preferred because it's less risky as far as triggering arrhythmias.
Yes, that's right.
Correct.
Yeah. That's right.
Thank you very much. Thank you.
No worries. Yeah.
With do you think it makes much of a difference using either 0.5 or 1 milligrams? Because just change in the latest ACLS guidelines. Do you think there is big difference in one versus the other, or pretty much the same thing?
Yeah, I mean, you repeat if 0.5 is not working. So I would decide on the estimated weight of the patient. You can go for 1 milligram. And you can go up. You can titrate. So yeah, there's not so much difference between 0.5 and 1 milligram. If no more questions, comments, then this is it today. Thank you very much all for the interaction. Very useful comments, questions. Hope you enjoyed, and you will get the link tomorrow if you want to relook, and hope to see you soon again. Take care and have a good evening.
Thank you very much, Dr. Guerra.
Bye-bye.
Thank you, Doc.
Bye. Thank you.
See you.
It's okay. I'll do